Now, continuing with the regional survey, as we have covered the upper limb, we covered the hip joint and knee joint, but we have left with ankle, equinus, and other deformities. Foot and ankle has to be dealt as well, and that has to be seen as well, because there are multiple abnormalities at the foot and ankle level. In this section, we will going through the how to deal with ankle equinus and whether it's a total body involvement and how to deal with that as well. So ankle is there is maybe associated with cavovarus or equinus deformities. I just told you in the previous section. This can be dealt with either you need a knee hyperextension osteotomy, or maybe there is a limited dorsiflexion because the ankle is in equinus. Gastrocnemius gastrosoleus complex, which is inserted onto the calling in form of tendo Achilles, may be tied. Therefore, we have to do the cerebrospinal test so whether the tendo Achilles lengthening would help in this or not. But if only the tendo Achilles lengthening is not only helpful, you may have to do some other soft tissue release around the ankle joint so that the equinus can be corrected. Coming to the treatment at this, usually multiple other bony procedures can be done as well, which include calcaneal lengthening. There may be a displacement osteotomy, subtalar fusion or subtalar arthrodesis can be done. There may be, before going on to the bony procedures, these tendon transfers can also be done, for example, peroneal tendon lengthening or plication of the medial structures, because usually these are associated with tightness of these areas. Therefore, their plication can be done so that the plantar valgus deformity can be corrected. There may be a supramallear osteotomy can always be done if there is too much angular deformity of the ankle joint. Other deformities include hip, knee, and the spine. As I just told you in the previous, there's knee. There could be a knee flexion deformity, which was previously dealt. There could be knee extension deformity as well. Sometimes this knee extension deformity is that the child may be in a hyperextended or knee recurvatum. Therefore, tenotomy of the proximal rectus femoris may be required. Or if this is there is associated external tibial torsion, this may require a supramallear osteotomy or some kind of a tibial osteotomy so that the external rotation of the tibia can be corrected. Usually, a single event multi-level surgery is required, that we have to deal with the hip, knee, ankle, spine at the same level, and that is why if we once or usually sometimes what happens is that some things can be corrected in one go, and then we can restart the physiotherapy in splintage so that the some amount of gradual correction can be done later on in post-operative periods. This is actually all the things that done to enhance mechanical efficacy of the limb so the child is able to actually walk properly. Coming to if it's associated with quadriplegia, then the problems could start from the neck till the ankle. As I've just told you, there will be in hip, there will be hip subluxations, adduction, flexion contractures, there will be associated cerebral dysplasia, and it's called as windswept hip, in which that actually instead of having a scissoring gait, this is called a windswept hip, in which if you can see this being like as if the wind is actually carrying them both the hips towards one direction. One hip is an adduction, internal rotation, and fixed flexion deformity, while on the other hip, instead of internal rotation and adduction, it is actually going to abduction, external rotation, and fixed flexion deformity. This is called as windswept hip or windswept phenomena. Similarly, this has to be done, as I told, by adductor release or iliopsoas release, and they may have to be done with other tendons which are actually externally rotating the hip. Treatment options include adductor and psoas releases, I just told you in the previous section as well. Femoral varus rotation osteotomies may be required. Acetabular procedures for the acetabular dysplasia may be required as well. Then may require open reduction and bony realignment. Excision of the proximal femoral end would lead to shortening of the femur so that this flexion contractures can be done. This may require release of hip abductors and extensors. Femoral osteotomy to decrease the retroversion of the hip which is present, and there may be reconstruction of the acetabular so that the acetabular dysplasia can be corrected and there is decreased subluxation of the hip or dislocation of the hip joint. Then coming to the spine, sometimes the spine may be involved as well, and usually associated with kyphosis and scoliosis. Scoliosis affects more than 50% of the children with CP. Usually, there is associated lumbar lordosis and maybe a C-shaped thoracolumbar curve, which can be seen on this photo. One hip is abducted and other is adducted. As I told you, there is pelvic obliquity, there is windswept hip, and there is spinal scoliosis as well. There may be trunk muscle involvement as well, and the patient may be so severely affected they are unable to hold their neck properly as well. So treatment is operative correction. In these neuromuscular disorders, we cannot go for bracing because there is actually severe progression of scoliosis, which may be 1 to 2 degrees in a few days. Therefore, if it's 1 to 2 degrees of progression in one day, in few days, they may be so severely kyphotic scoliotic deformity that these children may develop cardiopulmonary problems and they may not be able to survive. Therefore, the only option in spine in these areas is actually always the operative intervention, that we may have to go for some kind of posterior fusion instrumentation, which in form of spinal stabilization is required. As in this section, we have gone through what are the different scenarios in when the foot and ankle is involved. As we know that it could be equinovarus deformity, could be planovalgus deformity, but equinus is usually present due to tight gastrocnemius. In case of it's a total body involvement, there will be all kind of a contractures. There could be knee flexion contractures, there could be knee extension contractures, there could be external tibial rotation. These children, there may be associated with spinal scoliosis and kyphosis. And usually the spine cannot be managed conservatively. We have to go for some kind of operative. That's all from this lecture. Thank you very much. Keep watching sqadia.com.